Good afternoon, all. I have no financial interest. It's not moving. It's not moving. Can you reset the time, please? It's not moving. Now it's moving. Reset the time, please. Again, it is stuck. Not able to move.
Is not moving here?
No. Thank you. So, my study was to assess Adalimumab in the management of pediatric non-infectious uveitis, the assessment of efficacy and compliance. So, pediatric uveitis is specifically, its incidence is 4.3 per 100,000 population per year, and the prevalence is around 28. It is 20% of all uveitis cases globally, and it significantly impacts the quality of life because it begins much early in an individual's life. Methotrexate, although widely used, it fails to control the inflammation in about 40% of cases, and there have been trials which have clearly demonstrated the efficacy of biologicals, specifically adalimumab, over methotrexate in managing uveitis. The premise in managing uveitis in children is that we must reduce steroid burden, induce early remission, and maintain it, non-daily dosing, and minimize side effects. So with this in mind, we started out to assess the efficacy of adalimumab in pediatric chronic non-infectious uveitis and to evaluate treatment compliance. The efficacy was evaluated based on inactivity on fluorescein angiogram and ability to maintain remission without use of corticosteroids. And the treatment compliance was evaluated based on producing the empty box of the injection during next visit in the clinic. The study design was a retrospective study which included 14 eyes of 7 patients. Patients below 16 years were included. The mean age at presentation was approximately 12 years, and there were 4 males and 3 females. The children who were cooperative for ultra-wide field fluorescein angiogram and OCT were included in the study. No history of prior surgery or implant, whether anterior or posterior segment. Age must be below 16 years. No history of prior immunosuppression or failure to achieve remission if immunosuppression were started. Diagnosed to have chronic course of uveitis, which required failure to achieve remission in last 1 year without steroids, and no infectious etiology identified on complete systemic workup. We excluded children who needed multiple immunosuppressive therapy for systemic vasculitis, children who were not cooperative for imaging, previous history of biological use or poor compliance or default, and unavailable history of immunization or active or dormant tuberculosis. Disease-wise case distribution was, we had JIA with chronic anterior uveitis, 2 cases, Blau syndrome, 1 case, Behçet's associated panuveitis with vasculitis, 2 cases, pars planitis with macular edema, there were 2 cases. The adalimumab therapy was started in conjunction with methotrexate in all our cases, and it was administered subcutaneously, taught by us, self-administered at home, if they could not travel every time. Initial fortnightly dosing for 3 injections, followed by increase in the interval, which was increased to monthly. Fluorescein assessment was done before every interval was altered. All patients had undergone complete ophthal evaluation, workup, and were cooperative for imaging. Infectious cause, specifically tubercular etiology, was aggressively ruled out in all cases. The diagnosis was established after thorough examination by a rheumatologist, and all patients were initially started on methotrexate in combination with steroids, followed by adalimumab. The remission was achieved in all cases between 6 to 8 weeks. uh, except one case of Behçet's uveitis with panuveitis who did not achieve remission despite receiving 12 injections of adalimumab. And the side effects were also found in one case. Rest were quite comfortable with the dosing. So all patients demonstrated good response with adalimumab except one, despite 12 injections. Mean follow-up duration is approximately 15 months. 2 patients were lost to follow-up after 16 months, but they had achieved remission. However, we continued follow-up telephonically and remotely with consultation locally. Mean number of injections was 7. All patients received adalimumab in conjunction with methotrexate. The side effect profile was acceptable, and it appeared to be an effective option in pediatric uveitis as a primary therapy, which achieved remission in 6 out of 7 patients in our cohort. 2 were lost to follow, but we had followed them up telephonically. Adherence to subcutaneous regimen was good during maintenance. Only 1 patient experienced manageable side effects like myalgia, anorexia, and fatigue. This is the fundus fluorescein angiogram of the patient who did not achieve remission despite everything. And this patient was also given a trial of 5 days of IV methylpred, but the vasculitis did not show even 10% of reduction despite steroids in this case. We are still trying to figure out what this is. So pediatric chronic non-infectious uveitis is a challenge, and treatment-related complications needs to be managed in long-term treatment. With the subcutaneous monthly regimen, it is an effective in managing subgroup of uveitis with good compliance. Thank you.
Thank you, Dr. Samendra. Any question from the house? Sir?
It's not that capillary hardening will go away with the treatment. That's not the. A lot of times capillary hardening persists. You have to see the visual acuity, macular edema, and that will be the in case of eternity with the basal disease.
Yes,
and in case it is not responding to the adalimumab, the senior drug is infliximab that is little superior.
yes, sir.
That can be given.
So we are considering tocilizumab in this patient, but sir, except Ferning, he also had a very hot disc and disc leakage in the. That is the reason which. Yeah. Yes, sir. Yes, sir.
Thank you, Dr. Samendra.